Welcome everyone. In today's video, we are going to talk about the anterolateral approach to the humerus, which is a commonly used approach for fixation of proximal and midshaft fractures of the humerus. Coming to the technique of this approach, the position is supine position with the arm placed on an arm board, and tourniquet is avoided in this approach as it often comes in the way. The complete incision is from the coracoid tip following the deltopectoral groove to the insertion of deltoid. Distally, this follows the lateral border of the biceps till about 5 cm from the flexion crease of the elbow. Depending on which part needs to be approached, the length of the incision and the location of the incision is decided. Following this, we have to identify the deltopectoral groove in the proximal part of this approach and the cephalic vein which lies in the deltopectoral groove. There is some fatty tissue which surrounds the cephalic vein, which may help in the identification of the cephalic vein if it is difficult. Distally, we incise the fascia in line with the incision and identify the interval between the biceps and the brachialis muscle. We have to look for the lateral cutaneous nerve of the forearm, which is a terminal branch of the musculocutaneous nerve. This pierces the deep fascia at the lateral border of the biceps. So, this nerve pierces the deep fascia at the lateral border of the biceps in the distal part of the incision. This needs to be identified and protected. Following this, in the proximal part, the deltoid is retracted laterally after developing the deltopectoral interval, and the pectoralis major may need to be retracted medially. The cephalic vein is retracted laterally or medially depending on wherever it goes easily. The biceps is retracted medially to expose the brachialis muscle. Now, retracting the mobile ward laterally after developing the plane between brachialis and brachioradialis in the distal part will expose the radial nerve. Whenever we have to expose the distal part through this approach or distal 1/3 through this approach, we must expose the radial nerve to protect it. Once the radial nerve is identified and the brachialis is exposed, the fibers of brachialis are split in the middle. Now this, though there is a splitting of the muscle, this is an internervous plane, as the lateral fibers of brachialis are supplied by the radial nerve and the medial fibers are supplied by musculocutaneous nerve. After splitting, we have to strip the brachialis of the anterior surface of humerus to expose the humeral shaft in the middle and distal part. While stripping the brachialis, it is better to keep as much muscular attachment as possible to prevent devascularization and promote healing. Now, for the proximal part, insertion of deltoid may be released partially and deltoid retracted laterally to access the proximal humerus. Blunt dissection under the deltoid helps to expose the subdeltoid space for seating of the plate. If further exposure of the proximal part is required, insertion of the pectoralis major on the lateral lip of the bicipital groove may need to be released partially or fully. Now coming to the dangers in this approach. Let us see the nerves at risk. The first nerve is radial nerve. It is at risk in the spiral groove at the back of middle 1/3 of humerus and in the distal third of the arm in this approach. So in the spiral groove, the first risk is if we stray on the posterior surface of the humerus while exposing this. So we have to avoid this. And the second risk is while drilling or tapping for placement of the plate, we may injure it in the spiral groove from an anterior to posterior direction. So we have to avoid over penetration of the posterior cortex while applying the anterior plate to prevent damage to the nerve by drills, taps and screws. So in the proximal part, you avoid over penetration. In the distal third of the arm, we have to identify the radial nerve before splitting the brachialis. And also we have to place the retractors over the lateral half of the brachialis rather than directly on the nerve. And we should avoid using Humeral retractors in the distal 2/5 of the humerus, as these have been found to be associated with increased risk of radial nerve injury. The second nerve is axillary nerve, which runs on the underside of deltoid from posterior to anterior. For this, we have to avoid vigorous retraction of this deltoid to prevent compression injury. The third nerve is the lateral cutaneous nerve of forearm, which pierces the deep fascia in the lateral border of biceps just above the level of the elbow crease. So if dissection between biceps and brachialis is carried out till the distal extent of the approach, the nerve must be identified and protected. The vessels at risk are the anterior circumflex humeral vessels, which cross the operative field in the interval between pectoralis major and deltoid in the proximal part of the incision. Now, cutting of these vessels generally cannot be avoided, so these must be identified and cauterized or ligated. So friends, in this video, we discussed the anterolateral approach to the humerus. If you like these videos, please hit the like button and subscribe to the channel for further such videos. Also comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.